Everybody can see slides. Yeah, okay. All right. My name's Kayleigh Berner. I'm a nurse practitioner. I work with Ruby Hospital, WV Medicine in Morgantown. I'm a nurse practitioner with infectious disease. Today, I'm going to talk about hepatitis B and C co-infection, which I feel like I haven't done this didactic. It looked like the last time I did it was the 2023. So it's been a couple years. And I feel like we talk a fair amount, or at least run through hepatitis B serology and core positivity and yada yada when we're doing our echo sessions, but I'm hoping to just spend some more time talking the specifics, and then certainly we'll leave room for questions and discussion at the end. I won't be talking about, Hep B serology or specific Hep B treatments and whatnot. We'll kind of correlate those back into Hep C co-infection, but hopefully this will, kind of just give us some more time to spend on a dual infection. And so objectives today, certainly review transmission modes of both hepatitis B and C, and then also to discuss the viral interactions of each and the concept of a dominant viral hepatitis. Summarize our clinical features and outcomes of both Hep B and C related to co-infection, and then compare the impact of treatment on the coexisting virus, as well as describe indications for Hep B management on individuals who are planning to start Hep C direct-acting antiviral therapies. So with hepatitis B and C, as I'm sure we all know, but they have shared modes of transmission. Both are bloodborne pathogens and highly transmissible parenterally. Hep B is actually 5 to 10 times more infectious than Hep C, and the Hep B virus is really a lot more stable at room temperature. It can last a lot longer, even with dried blood spots. It's still highly contagious and can still remain infectious outside of the body for at least a week after. Hep C can survive outside of the body on average for typically less than 24 hours. But sometimes if the room temperature is right, it can last up to 3 weeks. But lower amounts of viable virus, so it's less likely to actually cause infectivity, even with dried blood spots. Hep C virus can remain viable, however, under the right conditions, like in a syringe, for up to 5 months. And so even though, it's not as viable out in the open environment, this is still why we always counsel patients not just to avoid sharing needles, but to also avoid sharing syringes, cottons, cookers, any type of device with injecting equipment. Hep B virus, on the other hand, so it's a lot more highly transmissible. It's not only found in blood, but it's also found in mucosal secretions, and it's much more efficiently passed through sexual and vertical transmission. Whereas Hep C, we typically think of this as a primarily blood transmissible virus. It's more common to see even incidental household contacts that also have Hep B compared with Hep C. And then if you recall, Hep C virus is, from our prior sessions, sexual transmission of Hep C is very low. So overall, it's less than 2% per year for heterosexual. Hep B in the US is actually primarily spread through sexual contact. So we do certainly have seen, since the early 2000s, upward trends of Hep B associated with injection drug use. And it's actually 50 to 100 times more infectious through bodily fluids than even HIV, which we always talk about HIV being so highly transmissible through sex and blood, but Hep B is much more efficient, both modes. However, in endemic countries like Southeast Asia, Sub-Saharan Africa, the primary mode of transmission for Hep B is actually vertical transmission. And so it's highest when you have a mother that has active Hep B, so meaning detectable or a high Hep B viral load or a positive Hep B antigen. can transmit mom to infant without any mitigation strategies. It's about 90% transmissible, which is really, really high. In the US, Hep B transmission is extremely low, but that's due to our implementation of mitigation strategies. So vaccinating the infant at birth, treating the pregnant mother who has Hep B, giving IVIG to infants, and that can really reduce vertical transmission by over 95%. And then if you also recall, because we talk about Hep C a lot more than Hep B, but vertical transmission for Hep C occurs on average about 6% of the time. There's some factors, HIV and co-infection, it can be up to 10% of the time, but much, much lower in terms of vertical transmission. And there's not really any mitigation strategies that are available other than certainly getting the mom treated before she becomes pregnant. And then dual Hep B and C infection, it's not uncommon in highly endemic areas and among those with high risk of parenteral infections. So worldwide, we see co-infection approximately 1 to 5% of the time, but that prevalence is really widely variable. So we see that a lot higher, especially in the US with injection drug use. Honestly, with patients that have chronic Hep C, we can really see Hep B either isolated core positivity or low levels of Hep B virus, really even in up to as many as 50% of chronic Hep C patients. Vice versa, if you have a patient that has chronic Hep B, we really tend to see lower levels of co-infection, but it still can be about 5 to 20% have Hep C antibody positivity. So they tend to clear Hep C, but we still see it a fair amount. Bottom line is, if you have one viral hepatitis, screen for the others. And so in terms of like viral interplay between Hep B and Hep C, individuals that have Hep B and C co-infection, they really exhibit a large spectrum of virologic profiles. And so what we know is that Hep C is usually the dominant virus. And that's why when we're talking about, hey, if you're starting your patient on Hep C treatment, make sure you're also testing for Hep B, and then treating if needed, or at least monitoring. And that's because we get concerned about Hep B flaring when we are using our direct-acting antivirals to eradicate Hep C. Why is Hep C usually more dominant? We don't really know the specific virologic and molecular interplay between co-infection. It's likely due to a mix of the host's immune response as well as viral competition for the host machinery that's involved in replication. But it's been suggested there are certain proteins associated with the Hep C virus, that actually inhibit Hep B viral activity and thus impede the function of Hep B polymerase. And that's what suppresses the Hep B viremia. But then when you treat the Hep C, that suppression's gone, and that's why you see Hep B flare. There certainly are instances where Hep B is the more dominant virus, but we just don't see that as often. And then spontaneous clearance over time of one or even both viruses can occur, but overall it's pretty rare. If you have underlying chronic Hep B infection and then your patient becomes also infected with Hep C, the underlying Hep B is actually a protective factor for spontaneous clearance of acute Hep C. And so if you already have chronic Hep B infection, then acquire Hep C, they tend to spontaneously clear the Hep C over 40% of the time. So it's still not high, but it's a little bit higher than what we tend to see with mono-infection. And then same thing, sometimes when you get Hep C superinfection on top of chronic Hep B, you can actually see Hep B surface antigen clearance or even envelope antigen seroconversion as well. And that occurs about 2% per year. Again, we don't know exactly why, but we do see it happen. So some of the clinical features of Hep B and C co-infection, it's not common to see simultaneous acute hepatitis with B and C. So it's typically superinfection. You've already gotten infected with one viral hepatitis, and then later on you get infected with the second. It's really uncommon to see simultaneous infection. Acute clinical features are comparable to monoinfection. And so they don't really differ that much. About a third of the time, you'll get a clinical hepatitis, like develop a serum sickness, jaundice, dark urine, light stool, nausea, vomiting, which can last up to a month or longer. But it's really not different if you already have an underlying hepatitis. The likelihood or the symptoms are still the same. In most cases, we don't diagnose these in an acute setting. We diagnose these in the chronic phase. But if you do happen to diagnose Hep B superinfection in a patient that already has underlying chronic Hep C, depending on how closely you're checking labs, but these patients tend to have a delayed appearance and then a shorter duration of Hep B surface antigen positivity, but you'd have to catch it. So, also, chronicity rates are comparable to patients with monoinfection of either virus. So again, small increase in likelihood of spontaneous clearance, but overall it's still uncommon. And then fulminant hepatic failure is significantly higher with superinfection compared with monoinfection, but it still occurs in a minority of cases. And so again, this is why we recommend, hey, if you have Hep C, we want you to get vaccinated against Hep B. In terms of clinical outcomes, there is conflicting data if the degree of liver damage is compounded by Hep B and Hep C co-infection. So some studies estimate that the risk of necroinflammation that leads to advanced liver disease could be increased up to even threefold with a more frequent progression to liver cirrhosis, liver decompensation with co-infection compared with monoinfection. But then there's some studies also that have really reported there's no difference in liver disease severity, whether it be mono or co-infection. The takeaway is that really there is such a large degree of damage that can be quite variable. And so each virus is going to certainly still exert its own pathogenic role, and that can be unpredictable and cause a cumulative effect of liver injury. However, in terms of development of hepatocellular carcinoma, we do see a clear synergism between Hep B and Hep C carcinogenesis. And so remember that with Hep C monoinfection, there's about a 1 to 4% risk of developing HCC per year. And that tends to happen once liver cirrhosis has already been established. So natural history, that's 20, 30 years after a patient's had chronic Hep C. With Hep B monoinfection, you really see liver disease progress at a much faster, unpredictable rate. So it can really develop at any stage, even in the absence of liver fibrosis. And individuals that have chronic Hep B overall have a 25 to 40% lifetime risk of developing liver cancer. With HCC surveillance, in individuals with chronic Hep B, it's really stratified based on certain characteristics. So like how active the Hep B is, so degree of viremia, a family history of HCC, Asian descent or African descent, more advanced age, etc. These groups in particular are stratified at having a higher incidence of HCC. So if you have co-infection, however, the cumulative risk is really going to depend on the Hep B replication status. So if you have Hep B C co-infection, but you have undetectable Hep B viremia, then really your HCC risk is going to be equal to Hep C monoinfection. If you have Hep C co-infection and active Hep B replication, then you're going to have twice the risk of HCC and a much higher increase in mortality compared with inactive Hep B. And that's really because of that X protein and the Hep B oncogenesis, which like really supercharges your development and progression for liver cancer. So again, bottom line, if you have co-infected patients with known or suspected advanced fibrosis, or they already have underlying liver cirrhosis, they should be followed regularly. So every 3 to 6 months with imaging, so HCC surveillance, and that's even after Hep C has been treated, and during Hep B treatment if their Hep B is being treated. And so think of it as, even if you see that liver disease improve, those histologic changes have already been established to the liver, and so they really proceed in neoplastic state. So you still want to be doing surveillance. In terms of treatment considerations, so goal of Hep C therapy is going to be cure or sustain virologic response through the use of direct-acting antivirals, and this is for overall all chronically infected patients unless they have a prognosis of less than a year that can't be remediated by Hep C treatment. Hep B treatment, on the other hand, there is no cure. It's really virologic control, and it's using a risk stratified treatment algorithm for chronically infected patients. So there's more, it's more of an algorithmic approach in who would qualify or who would benefit from hepatitis B treatment. And that really comes from the fact that Hep C treatment's going to be 2 to 3 months. It's a succinct course. In most cases, it's not going to be a commitment to lifelong treatment like Hep B therapy is in most cases. And there's also not going to be the risk of, if you stop Hep C treatment, it can flare and kill you. With hepatitis B, if a patient falls out of care and they just stop taking their meds, they have a risk of Hep B reactivation. And especially if they have advanced liver fibrosis, it can kill them. So in some instances, it can do more harm. And so that's why we're a little bit more strategic in who we opt to treat Hep B for. And then there is some acute hepatitis B and C treatment that's been described, but that's not going to be within the scope of today's session. It's honestly not something that I've opted to do, so we're not going to spend time on that. And so what about the impact of treatment on the coexisting virus? And so if you're going to take anything away from this session, this is the slide, because this is what can kill. So Hep B reactivation during and after Hep C therapy is what we really harp on in many of our HCV echo sessions. And that's why we always want to know the full Hep B serology panel, because Hep B reactivation has the potential to kill your patients. Okay. What this came from was actually, this is post-marketing, but the US Food and Drug Administration issued a drug safety warning October of 2016, in which they identified 29 cases by publication of confirmed Hep B reactivation in individuals that were receiving direct-acting antivirals for Hep C treatment. The severity of damage, it really ranged from a silent Hep B reactivation, so Hep B viral load increased on lab work, but they didn't have clinical hepatitis, ranged to fulminant hepatic failure that required liver transplantation, and then 2 deaths were also reported in these cases as well. And so the clinical events were more common in individuals who already had baseline detectable Hep B surface antigen, and were much lower in those who had isolated Hep B for positivity. But this was regardless of which direct-acting antiviral was used. And so it typically also happened about 4 to 8 weeks after the DAA initiation. And so that's typically when your HCV viremia is going to be sufficiently suppressed, is when you see that flare happen. But it was even seen to occur even post-treatment and occasionally up to through SVR12. So this led to a black box warning that was added to all DAA drug labels that just states basically that if the patient has current or prior exposure to Hep B, there's a risk for flare, and all healthcare providers should screen for Hep B at baseline and monitor for Hep B flare or treat for Hep B when indicated. And you still want to follow up during treatment and post-treatment as well. So after that initial statement was issued, there was a systemic review and meta-analysis that was subsequently published in 2018. And this really showed that clinically significant Hep B reactivation was most frequent in patients that had a baseline positive Hep B surface antigen. And so we would see flare or reactivation occur approximately 24% of the time in this meta-analysis. And it was pretty rare, but still occurred. It's less than 2%, 1.4%. You would see reactivation in individuals that had an isolated Hep B core positivity. So surface antigen negative, surface antibody was negative, total Hep B core was positive. You'd see that about 2% of the time, a reactivation. Interestingly, the risk of reactivation was not clinically significantly different in patients that already had underlying cirrhosis versus patients without cirrhosis. However, these are the patients that if they reactivate, it's more likely to kill them. So we still want to be very mindful of the severity or the seriousness of reactivation. Also, the risk of Hep B reactivation related hepatitis, so clinical hepatitis, it was approximately 9% in those that had chronic active Hep B. However, no clinical hepatitis was reported in those that had a baseline isolated Hep B core positivity and an undetectable baseline Hep B core DNA. So really, to summarize, to stratify the risk of Hep B reactivation during and after DAA therapy for Hep C, at baseline, you want to obtain your Hep B surface antigen, your anti-hepatitis B total core antibody, and your anti-hepatitis B surface antibody, as well as checking certainly your liver enzymes and also knowing your baseline liver fibrosis status. So what do we do? What do we do with that information? If you have a Hep C patient with chronic Hep C wanting to get them on treatment and you do find that they have hepatitis B, really the treatment recommendations vary upon depending on which guidance that you're looking at. And so the European Association for the Study of Liver Diseases, their most recent guidance was came out in 2017. They recommend to treat if your patient has a positive Hep B surface antigen, you treat prophylactically until 12 weeks post direct acting antiviral completion. If we're looking at the American Association for the Studies of Liver Disease guidance, which is usually the one that I tend to refer to because our hepatologists here at WVU use that as their resource. That was updated last in 2018. They recommend that you don't really have to treat if you just have a positive Hep B surface antigen, but you'll treat based on chronic Hep B guidance. So if you have somebody that has Hep B surface antigen positivity, you're going to monitor the ALT and Hep B DNA every 4 to 8 weeks during treatment through 3 weeks post DAA completion or SVR12. And then you would treat if they meet Hep B guidance, their Hep B treatment criteria. The Asian Pacific Association for the Study of Liver Diseases, they state to prophylactically treat patients that have baseline advanced fibrosis, cirrhosis, or prior hepatocellular carcinoma. Treat all of those patients until at least 24 weeks after they finish their DAA therapy. And then if they don't meet that criteria, then consider prophylactic treatment or close monitoring. So this is my opinion, and this is my approach with my clinical practice. Because there's a lot of guidance to consider. Like I said, I tend to lean more towards AASLD guidance, but I just have a couple slides that I like to go through my thought process and how I personally approach patients that have positive Hep B serology. So if you have a positive Hep B surface antibody, and then a positive or negative core antibody and a negative surface antigen, that's your safe zone. That means your patient's immunized or protected from Hep B flare, whether it be they've gotten vaccinated or whether it be that they have natural immunity because they've had prior infection. If your surface antibody is positive, that's your safe zone. Proceed with your DAA treatment. You don't need to do any additional monitoring. They're protected from Hep B flare. Okay. If you have a patient that has a positive core Hep B antibody, but they have negative surface antibody, negative surface antigen, this is what we refer to as that isolated Hep B core positivity. So these patients are at risk for flare, but they don't have, at least up front, evidence of active Hep B. It may be a occult infection. In this instance, check your baseline Hep B DNA, as well as your pre-core Hep B E antigen and Hep B E antibody. If their baseline Hep B DNA is not detected, you don't have to prophylactically treat. They're at less than a 2% chance of reactivation. You'd monitor their AST and ALT every 4 weeks while they're taking their Hep C treatment. And then if those values increase more than twofold from the baseline, then you can go ahead and obtain a follow-up Hep B surface antigen and quantitative Hep B viral load, and then treat accordingly if you need to. And that would be according to treatment guidance. If you're checking at baseline that Hep B viral load and it is detected, then you can go ahead and consider prophylactic treatment if the patient also already has underlying advanced liver disease or they otherwise would meet Hep B treatment criteria. And I'm not going to go through all the Hep B treatment criteria because it's a big algorithm, but it's pretty easily accessible. I can certainly always share it, but you can get that through UpToDate has it, AASLD has it as well, but that's not within the scope of today's discussion. If you have a patient that has Hep B surface antigen positivity, without even looking at anything else, you want to go ahead and check a baseline Hep B viral load, as well as your pre-core E antigen and E antibody. And then I go ahead and would prophylactically start them on Hep B treatment. And that would be preferably 2 to 4 weeks before you start Hep C treatment, if possible. But in those instances, they have active Hep B. You still want to check their viral load, but because they're at a much higher risk for flare with Hep C treatment, I go ahead and prophylactically start them. And then typically, you would continue your nucleoside inhibitor for at least 3 months following DAA treatment completion, so through SVR12. If you stop it at that point, you want to continue to monitor for Hep B flare. Typically, we'll treat with either tenofovir or entecavir. And Dr. Gilfus has done didactics on Hep B treatment options, so we also can send that slide set out again as well if you'd like that for reference. But again, you can look at the AASLD guidance on Hep B treatment. So how does Hep C reactivation play into if you have a patient that's being treated for chronic Hep B? So when Hep B replication is inhibited by antiviral therapy, you can see a reactivation of Hep C. It's possible. It's rarely observed because typically your Hep C is going to be your dominant virus, and it's clinically insignificant in most cases. So with hepatitis C, even if your viral load jumps from 100,000 to a million, it's not clinically going to change your progression, your prognosis, your symptoms. There's no correlation with degree of viremia and extent of liver disease related to Hep C like there is for hepatitis B. You want to certainly monitor for signs and symptoms of clinical hepatitis, but there's no specific guidance on Hep C monitoring while you're treating someone's Hep B. So you just would proceed as you would otherwise. And then that's it. That's my slide set. I have references. I always put up to date and CDC first because those are always the resources I go to first, but I also included some articles as well. And so I think CDC also has a YouTube link, a video that really goes through Hep B serology itself. Because I know that even in and of itself can get a little confusing to interpret until you've done it several times. I usually still have to go back and refresh my memory if it's not something that I see a lot, especially if you're thinking of like the pre-core mutants and it can get convoluted. But hopefully that helped kind of make it a little bit more standardized on how to manage Hep B and C co-infection. So I'll stop my slides and stop sharing my screen, and then I'm happy to answer questions if anybody has any.